Hello and welcome to Slice of Piefer. I'm Dr. Piefer. Thanks for being here. We have with me today my sidekick and personal physician assistant,
Okay.
Taylor. Welcome.
Yeah.
And we are blessed to have cardiologist, chief medical officer, superhuman, awesome guy, Gary Vadala. Dr. Gary Vadala, thank you so much for being here.
Thank you so much for
awesome. We have had the opportunity to work together for quite some time now, over the course of the last 4 or 5 years, I guess, since I've been doing some medical administrative things. But welcome. I am just excited to have you. How's everything going?
Oh, things are going well. Thank you so much for the invite. It's a gorgeous day and really excited to be here and excited to see you doing all the things you're doing on your podcast.
Yes. Well, it's just launching into outer space currently. When we hit triple digits, we're going to make an aluminum foil, you know, what does YouTube give you? Yeah, some sort of a plaque of some sort so that we can do it. It's going to be awesome.
Yeah, the Piefer Association is going to give you a plaque for your podcast.
Right. Except this is going to be from my children and it's just going to be garbage from our house. It's going to be so good.
I don't know that your kids would even give you the garbage plaque.
You're right. That is also true. But, well, welcome. So Chief Medical Officer. You've been Chief Medical Officer at Memorial Hermann, the Woodlands Medical Center for how long now?
Now it's about 3.5 years.
3.5 years. Yep. That's awesome.
Yep.
And so let's see. So I would have been Vice Chief of Staff for rolling into that mode right when you started.
That's
basically
exactly right. Yep.
Got it.
Yep. It was that same year.
Gotcha. Very good. Very, very cool. So I just want to hear a little bit about that transition because obviously you had to make that choice. You were a successful full-time cardiologist, had leader of your own group. You were leader of your own group, but then to transition into administrative medicine, that's a pretty big decision, but also a pretty big change just in terms of life. And how did you make that decision?
Sure. So I guess I'll back up to kind of when I got into med school, we all try to do various things in med school, and you end up either joining clubs or starting things. And, I just kind of gravitated towards creating some of those things myself. Then you go into residency. And as you know, there are chief residents, right? So I was at Washington University in St. Louis. And so there's 35 residents a year, pretty, big program. So I was chief resident there for a year there in our third year. That was kind of an interesting process, just the concept of trying to manage all of those. And we had to deal with schedules. We had to deal with gaps. I was at the VA hospital. And so that's where the chief residents spent their time. And those were the days when residents were very much a see one, do one, teach one. There weren't attendings, monitoring all of those types of things. You were just doing everything, and particularly in the VA again. So we were staffing ERs, we were doing procedures, and you were the person to go to if any issues arose from a chief resident perspective. Then I did fellowship. That was a 4-year fellowship. And then I joined a large group in Ann Arbor, Michigan, cardiology group, single specialty group. So that had... at that time, maybe about 27 cardiologists or so at the beginning. And that organization had a very nice structure to it. They had a representative board. They had good bylaws, governance processes. And so that was one of the things that I liked about it. And that allowed me to kind of go into that space, learn that space. And then I did what I kind of tell, most people who ask about this, you show up, right? So the first step is always showing up to the meetings. They had processes, so they had board meetings, they had an operations, they had research, they had certain committees, and I would just show up to those things, and you move from kind of showing up to kind of raising your hand, so when you raise your hand, you end up then managing change, and then you move from kind of raising your hand to having people hold hands together towards a particular common goal, right?
Right.
That's when leadership takes over, and as you kind of go through that process. I just did that in that particular organization. And so just went from, one of the junior non-partners to then partner, and then ended up going through their operations committee and leading that. And then I became president of that particular group. Then from that, as 80% of cardiology groups throughout the country, we became part of the hospital because just of the way the revenue implications were for most cardiology groups. So then that gave me then the hospital portion. So I ran that hospital and then kind of chaired what was called the cardiovascular kind of governance committee, which had the CEO of the hospital, chief medical officer, and other hospital leadership, and then physician leaders as well. And I chaired that particular committee for 3 years. During that time, our separate cardiology group ended up being subsumed into the more larger what's called physician enterprise at that hospital, which was some 450 multi-specialty physician group. And then I ended up on the board of that particular group during those same 3 years that I was running the practice. So then that allowed me to kind of see how a multi-specialty group is run that is part of the hospital.
Sure.
And then, so, my trajectory was going in a particular direction in Ann Arbor. Right. Then my wife and I kind of made a very strategic priority shift. We just kind of, our kids were at the right age, went through some, medical issues. And so we said the support structure is down in the Woodlands. My brother lived in the Woodlands. My parents are going to be retiring in a couple of years. And so in 2014, decided to move down to the Woodlands. And so that was a major shift. So I went from kind of running a large practice. By the time I left, there were 35 cardiologists, 300 employees, big group. And I come to the Woodlands, and now I'm just going to take a job in a 4-person cardiology group that was running around, going to multiple hospitals. So that was a big shift. I was literally going around with my resume, just showing it and doing cold calls, trying to find a job. So that was interesting. I use that story for my kids when I say it's like, you never know what life is going to give you.
Right.
And you just have to kind of go and see where things go. So I joined that group for about 3 or 4 years, 3 years. It was very different. I was very much used to kind of being in a system, being very organized with kind of how we delivered care. And I was very used to kind of hospital metrics and those kinds of things. Private practice here, you're running around. At that time, I was running around to literally 4 hospitals.
Right.
This had just been built. And so I was sitting there kind of running around, and it just wasn't an optimal situation. Opportunity arose within the employed Memorial Hermann Medical Group cardiology group. And at that time, it was 5 people, I think. So I joined that and then just was with them for about 5 years. And during those 5 years, we expanded to about 10 physicians, and I was kind of the leader of that for the last few years or so. During that time, I was also, again, showing up and raising my hand at the system level meetings for Memorial Hermann, what we call our clinical practice committees for cardiology. They had just started this concept of service line management, which again in Michigan I was coordinating the heart and vascular service line there from a physician lead perspective. So we were just starting that here, and they started a governance structure, and so I was part of that initial governance team for the system heart and vascular service line. And then Dr. Langen then made a decision in 22, I guess. To kind of step away, and he ended up leading a whole bunch of ERs.
Right.
And then our CEO at that time, Justin, kind of offered it. It was a tough decision for me because throughout all my time, so as I was leading the groups, one of my paramount things was I wanted to still be predominantly clinician. If you're leading a bunch of physicians, and particularly the structure I was at, it was very much a partner concept. It was a voting concept. You had to keep your physicians happy to continue in the role that you wanted to be. And it was very much, you're not going to have credibility if you sit there and say, I'm going to do, 70% administration and 30% clinical. So I kept to an 80% clinical schedule while I was also going to all these meetings and things like that. And so that was definitely difficult.
I
think
2 careers.
Yeah, it was, very early morning meetings. I had evening meetings at the multiple clinics we used to run. And so what I found was doing administrative work was always add-on, even when I was in all of my roles. So when this opportunity arose, I then, had to do a bit of a mindset shift. It's like now, okay, do I want to do this? Do I want to limit my clinical stuff, but see if the administrative skills that have come about first, are they good enough? Because I haven't had this type of role ever before in terms of a chief medical officer outside of the heart and vascular space. I felt very comfortable in the heart and vascular space. But that was exciting also, but also a little frightening. Having to deal with pediatric stuff, ortho stuff, surgical stuff that outside of, again, cardiac stuff just wasn't my forte. So a lot of that kind of conversation. But it allowed me to kind of say, well, I mean, let's try it. After now, it's been 30 years. I've kind of been in the business for a while.
Right.
30 years of a lot of clinical. I said, okay, I think I can take that step and go more administrative and see how things are. And so I was very happy to have had the opportunity to step up, and it's been a fantastic learning opportunity. That's what I love about medicine is you get to learn every day, and when you shift into a role like this, there's just daily learning as well.
Absolutely. So one thing I didn't hear, and you didn't have to go get a master's in public health or any of those extra, some things that you may see as people are looking, driving down the highway, you see Texas A&M public health or something. You basically got your education on the ground throughout all of your experience, it sounds like.
Indeed. OJT, on the job training, I would say now as I mix with other CMOs and go to these, the regional or national conferences, I do think, there is a shift happening. When I took my role at that time, there was a new organization that was called the American Academy of Physician Leaders. Now I think it's American College of Physician Executives. So that organization was just starting. I was in, I think, the first or second year of that, and I did a few of those courses, but I didn't continue it just with all the transitions that were going on. But indeed, nowadays when I meet with these other meetings, I do see a lot of the CMOs have some form of either leadership training. They have an MBA, MPH, MMM, which is Masters in Medical Management. So all those different credentials I see for those people who want to go straight into leadership. I did not go into medicine to do leadership or administration. It was just one of those things where I think it was literally just you show up, you hear an issue, you try to solve an issue, you find people say, okay, that sounds good, and you end up just leading that way.
Right. And the doors just keep opening and you keep getting a chance to walk through, which is very cool. Very nice. So what do you think are the biggest challenges? What are your bigger challenges? I can tell you mine from the chief of staff side that I wasn't expecting, but what challenges did you see as you transitioned out of the clinical realm into that more administrative realm? Whether it was personal challenges, professional challenges, or kind of sometimes dealing with it would be. Because now are you still 80-20 or are you more like 90-10 or 95-5?
It is 95 administration and 5% clinical in terms of hands-on clinical.
Right.
But that being said, every day I'm dealing with clinical issues,
situations.
Right.
Yeah.
So it's, am I taking care of the patient myself by bedside? No. But am I dealing with, hey, I got this patient who needs to get transferred, or I got this patient with this complex scenario. Right. How can you help? Who do I need to call? What is the prioritization? And then probably a bulk of it is also when we have service recovery options or complex issues, right? So there you're trying to engage with the family, doing family meetings. I'm active on the ethics committees for both hospitals. I think that's something that's not as well, frankly, known by a lot of the med staff, but there are, a lot of complex issues in the hospital.
Sure.
And so those are things that we deal with pretty frequently. But in terms of the tough stuff, when you become a physician leader, the first dynamic is always you're the person to go to when they have physician problems, right?
Right.
And again, that was nothing that I was trained toward, right? We were just told to go help, and you try to do the best you can. Even as a chief resident, it's not like they give you any skills. Right. At least I get back in the old days. Now I think a lot of those things have changed, but back in the old days, you were just like, it's a title, but it really just means you get to be the person that complaints get lodged to, and then you have to kind of figure out how to manage that. So I think the initial part is always how to just deal with physicians. So recognizing that it's not so much often physician resistance to something, but it's rather physician engagement, understanding, or trying to show that whatever you're trying to do has good, positive outcome, right?
Right.
I think that physicians align. I mean, the luxury of being in healthcare, vast majority of people are in healthcare to help people.
Right.
And as long as you are able to align towards that, I think you can get the changes that need to happen. So I'd say that's the beginning challenge as a physician leader. But then really the issues within healthcare are never about lack of knowledge, but it's lack of execution. Right. So how can you get your healthcare strategy to go from the cloud down to the frontline staff in an effective and robust way? That's what the leadership portion, becomes. And it's always difficult no matter how many decades you're in it. There's just a lot of challenges in being able to do that.
Right, for sure. Taylor, you've gotten to see some physician behavioral and communicating. I mean, you've had different physician leaders that you've worked with, also trained with.
Sure.
Where have you seen those things come in? Because it's a different view from the CMO view or the physician colleague view, and then the employed physician assistant, or just working because you're also taking calls. Sometimes you're having to interact with physicians. Where do you see that? How does that affect you?
Well, it affects us a lot. And the biggest thing is the communication, like just the other day when I was sitting in PACU and one of the doctors was frustrated because I haven't had to do discharge summaries like this for outpatient surgeries for 30 years. Why do I have to do it now? Well, because they say you have to do it. Does any normal doctor take that well? No, not just because it has to be. You need to give me the reason, right? And if we know how it affects the patient's reimbursement, anything like that, so what does that do for the person in my role? It means a lot of times those physicians are going to dump those extra responsibilities where? Right here.
Never.
And so if I understand why it's necessary, why it needs to be done, again, I can do my job effectively. Not only that, I can probably come up with ways to do it more effectively, right? Where it takes less time, where it takes less effort so that it can be batched or taken care of. But a lot of times what it ends up in is just, well, they say we have to do this now. I don't have time to do it. You take it. You don't ever do that.
Never happen.
No.
Never.
You are a grade A surgeon doctor who takes care of all his stuff and never punts any responsibilities to the PA.
Never, ever.
But that is something that definitely happens. I mean, and if there's communication about the why, if that surgeon understands, well, the reason we have to do this now is in order to optimize our reimbursement and for you to get paid better and the hospital to get paid better, this demographic, these words need to be used in a discharge summary needs to be done, even if they're only outpatient day surgery.
Right.
They're probably going to be more compliant with getting that done. And again, then we can get the tools there that are needed to make them do it efficiently.
Sure.
So it's not taking an extra 15 minutes of their time, which is what this doctor kept saying is 15 minutes of my time, 10 times in a day. It's 150 of my minutes. You know how much I charge for 150 of my minutes?
Really? That sounds very interesting.
And you know what?
Dr. Vadala has never heard anything along these lines.
I guarantee you both know this surgeon, and he's really nice.
Yeah.
So, that's just the.
We're both looking at each other. I probably know. The crazy thing is that I'm very bad at doing those things in terms of being able to do them and come up with them myself. But once I had you, like literally the amount of time it takes to do a short stay summary or a discharge summmy is like probably less than 15 seconds. Like it's nuts.
When you come up with processes,
like the short, like once you've done the operative dictation and sign that, and then you go to the short stay summary, it's already done. And so you can sign that, like it's just click. That's the amount of time that takes. And
remember
then go
me
to the
telling
discharge
you
summary.
to, like, hey, if you'll do it in this order, it takes these steps out for you.
This is a true story. She's like, if you just do it this way, you won't have to retype it every time. And I was like,
I don't want to do that.
I don't. I mean, I pout a little, only a little.
Once you realized it was going to be less work for you, then it was fine.
I mean, but now that you're not at the hospital because you're in the clinic, I do them all the time. I can understand the physician side of like, this is different, right? And that's where you see that change. Like when things change, all of a sudden everybody's like, Epic. We went through Epic. What's that? Has it been 2 years now?
Yep. It's October of 24.
We went through Epic, and that was like, the sky is falling, and I'm sure the Epic guys were talking with you saying, hey, this is going to be, this is how it's going to look. And I'm sure it was very similar to what people thought. Like there's a million different tickets and other different things that happen. But now we kind of keep going. And maybe I'm just a simple country doctor, but I'm like, well, I don't really remember how it was in Cerner. So, and things seem to be fine.
That's exactly it. I mean, change management, again, just as any physician leader or any leader of a hospital, change management is always challenging. But it is that portion that is so difficult, is getting to the kind of at the elbow support to show the physicians the easy button for some of these things, which are unfortunately at times regulatory or things that we're just kind of perceived to be mandated to do. And when it seems a little variant to another hospital because the Epic infrastructure is slightly different, or the manner in which certain fields are are able to be taken from the record to be able to meet regulatory requirements, that is the variance that makes it challenging. But it is that we need that level of support where we just have someone next to you and be able to show you it's not 15 minutes. It literally is 15 seconds. But you just have to know the buttons from which to do it. And even some of our leaders, some of the things we don't make it clear about what needs to happen. So like a short stay summary doesn't necessarily need to have a full physical exam portion or things of that nature. And yet if you use a particular smart text or something, it may say it needs to be there, but it's not really required. It is just other fields that have to be in there. So we got to learn that, educate towards that, and make it easy for the docs.
Well, and Taylor knows, but I am not a huge checklist person, like when it just comes to everyday life, but when it comes to the hospital, having like those boxes to check, like doing the short stay summary, it's like that little moment of check that off, check that off. I sent the meds. I signed off on the. I OKTA verified this. I signed off on the. And so for me, it's like a little tiny thumbs up. Way to go! So anyway. But I think that it could easily be frustrating to say, hey, why do I have to keep doing this? But it's just a bit of a mindset shift, to just say, hey, we'll get through this and
it
do it.
Forces you to do certain things. That's the intent of all this, right? So there are so many different things, but if you read any of these healthcare books, Atul Gupta had his big bestseller, which was the
checklist manifesto.
Things, exactly. And so that's that same concept. And how many times do you go through and go, that's right, I have to click on follow up and I forgot to tell the patient this specific follow up.
Right.
I've done that many times, right? And it is just that process in a busy day with our interruptive world that we live in. Our train of thought is just very easily deviated.
Right. One of the other things that we see, so you get to see this. So I was going to say the thing that I was most surprised about was physician behavior, right? I mean, that is one of the things, without going into specifics, but just seeing how physicians respond when the pressure gets dialed up was very eye-opening to me as I got into kind of the administrative side, because one of the former chief of staff was like, hey, I think that you would be good. You should come and come to more of these meetings and show up, kind of like you said, and see what happens. And then that sort of was also the way the dominoes fell to get to where I was. But I was very surprised to see, because that's not a world, and I kind of imagine that for you, although maybe leading the kind of a bit bigger groups, you saw that in cardiology, but that sort of how physicians, there's like several different ways that you break down under pressure, and it is pretty telling about how, like, where you struggle, and that has been interesting with just specifically for me understanding in physician behavior when the pressure is turned up,
No doubt about it. I mean, I think my first sense of it was really internship. So again, in internship at the facility I was at, we ran the hospital. Interns ran the hospital. The residents were moonlighting while they were supposed to be covering us, that kind of stuff. And I would hear about my other intern colleagues who just treated nurses not in a very nice way. And as an intern, the nurses know more than you do.
No doubt.
And I clearly remember, I'm just like, of course you're going to be beeped all night because the nurse is just very annoyed with you. You don't treat them in a good way at all. You don't give them respect. I had docs who were like, I'm the doctor, you follow what I tell you, even when it was, perhaps not the best thing to do. And so I realized early on that it's just that those going to med school, being smart doesn't mean that you have those particular people skills. And that is, I think, something that we all need to register. And, I now in these roles that we have where we're actually talking to A&M med school or Sam Houston DO school. It's like, I say you need to spend time with that. Every physician is an inherent leader. Whether you're even in a solo group,
Right.
you are leading your office staff. You need to be able to know how to just speak with people in a collegial manner, how you can have crucial conversations, how you can manage those relationships in a way that is better for you. So for me, I clearly recollect that in an internship. And then when I was as a chief resident, as I said, I ended up being the person that we would do that. But again, there was no training that I had for that, all
Right.
on the job stuff. And then as I went through, crucial conversations is a common thing, right? That now they try to teach you. But a lot of it is just, I have that inherent thing of, positive intent, try to be very neutral. There's always 2, 3, 5 sides to a story, depending
Right.
upon what the story is. So trying to go in neutral, hear what it is, align what you heard, go through what the expectations are, and then have them, amend toward that is really what our goal should be. So as long as I think you try to move with that concept, you can get some change. It can be difficult with certain ones, but as long as you have a plan for it and a process for it, that's I think what we have tried to structure, as opposed to dealing with every anecdote in a different way, or dealing with it in a way that a clear escalation path is not made.
Yeah. And I love that. I mean, I think to me, it's refreshing to be there, but it's also helps to recenter you to understand why are we here, right? Because it can become such a personal battle between the physicians and the nurses, between the physicians and patients, and it doesn't have to be personal. I mean, it should be personal in hopefully a positive way, right? That we're all here for the same reason. We're all trying to do the same thing and do what's right. But that's been Taylor and I worked on this leadership diagnostic quiz that takes when pressure turns up, where do you fall? And it was kind of funny because as I was helping to build this thing, I was like, these are the other guys, like the person who's the tyrant, who's, led by productivity, uses people as tools, but doesn't, when the pressure goes up, they become almost really for that person fits the narcissistic bill, which oftentimes surgeons fall into that bill. But there's the pleaser, right? Who avoids conflict and avoids confrontation and does that. It eventually at the loss of their team, right? Because good people want to get better, right? And if there's opportunities to get better, you should offer that. Anyway, we worked through all those things. And then I took the quiz and I was like, well, I guess I do have some of those tendencies that are in there. And so it was interesting, but like we've gotten to see that, like you see the delay and, the analysis paralysis, right? You see the people who just keep ordering tests, or you see the people who have a million different things happening and they're trying to micromanage everything and not delegating anything, but in reality, they're not getting any of the big things done, right? And so they're distracted by a million different things. And so it's been really interesting to get to see that from a leadership side. And I mean, I still was at 2 meetings today, but I loved the opportunity to be able to lead in that way. And that's not necessarily something that I would have guessed would have been as fulfilling as it has been for me, in the medical leadership at the hospital. So
you do a fantastic job. So, I think that's really, we need peer leaders. We need clinician leaders. We need a bench of those types of physicians in whatever health system that you can have, right? Because I think that's imperative. If people are not engaged, if your peers are not elevating you, making you better, it's always, difficult.
Well, and that's the super exciting thing where we are. I mean, in the meetings today, in our medical executive committee meetings, like you do have just great physicians and team members who are all in there. And that part I think is pretty inspiring to get to have those folks who are not only giving their time, but they also are committed to making the hospital better, to making the system better, to making their own every patient experience better. And so that's really fun just to be a part of that, is
Absolutely.
Really cool. What do you think as you look towards kind of our hospital and the bigger hospital system over the next 5 years, 10 years, where do you see things changing? I mean, we see so much craziness in terms of AI, in terms of technology. Obviously, we've had the big epic change within the last 2 years, but if you were looking forward, what do you think is coming? Not that I'm not holding you to it, but as we continue to navigate the world of healthcare reimbursements, delivering the highest quality patient care, what do you think are going to be the big changes and challenges that may be coming for us?
Yeah, so I mean, I think that there are a lot of big bucket items, I think. So, technology is going to be one big bucket. So how are you leveraging technology in a way that will allow you to be efficient and get the biggest bang for the buck? So for me, again, we do get skewed as you become, looking at hospital systems and stuff. You're looking for sentinel events. You're looking for the patients that are decompensating. You're not looking at you are looking at the denominator, but it is the numerator of events that you are driving to reduce, right? So you want to be able to get a technology that allows you to be able to reduce those numerator of fallouts or whatever metrics you're going to be kind of targeting. So that's, I think, where we are going to be trying to deploy those things. The tech is so much there. Sometimes Memorial Hermann tends not to want to be on the bleeding edge, right? I think we want to see 3 to 5 years of some other system utilize the tech and then make sure that it actually seems to work out and then try it. So now we're going to have these smart room technologies within the hospital. So that's a big initiative. We already have AI deployed both within Epic, but now also within these chart scraping large language model options within Epic, regard AI and Epic AI being kind of the two. I think those are incredibly valuable. I mean, the cognitive burden on physicians is huge, right? Why do we ask our APPs, you do the H&P first and I'll come and talk to you afterwards? Because we want someone else to go through all the millions of electronic records that are there, whether that be Care Everywhere or anywhere else, and summarize everything for me. Well, now we have tools that allow you to kind of just pick that up, right? I think that's going to be incredibly powerful. I remember, again, back in my internship days, we would call the medical records room and I would get a pile of charts that I'd have to go through, and I would have to sit there through the night. I'd have to have everything. And if there was a history of COPD, I was supposed to have found the FEV1 on a PFT from a year ago and present that there. And if I said COPD without an FEV1, my attendant would be like, you go find that now. It's that kind of level of detail that I grew up with, and it was so difficult to do that when you move into the EHR era, because it's just very difficult to find. But now you can actually do that so much easier. So I think the combination of those things will be very powerful in the technology era, with the smart rooms hopefully allowing us to have kind of patient early warning symptoms, deterioration indexes. These are all different tech that I think will allow us to kind of find the sicker patients earlier.
Sure.
So tech is going to be one big thing. Finance is going to be a continual challenge for us, right? So Texas has been in an environment where it is so predominantly fee-for-service. We just don't have a lot of these value-based contracts. It tends not to be, even though we're on Memorial Hermann, this road to value. If you look at other markets, whether that be California, the Northeast, where I was at in Ann Arbor, we had a lot of these auto companies that had very much quality-driven or performance-driven incentive insurance plans that forced the physicians to know about bundled payments, that forced us to actually create bundled payment contracts. And that's all stuff that in this market is still, not the majority, right? So it's a question of trying to figure that out. So both trying to deal with creating a road to value within our system, but then also managing the turbulent times of healthcare economics.
Right.
AI is being deployed both from our perspective to be able to capture how sick our patients really are. I mean, when the chart became a billing record, that was such a big change. Again, that happened from when I was in training, and that was the attendings all spoke to it. Now the chart is a billing record. It's horrible to go that way, and that's really what's happened. So now we've deployed AI tools to be able to capture how sick we are. The insurers have deployed their AI tools to reject, various things if certain things are not clicked. So those are two big buckets that are out there. I think then the third bucket that I really feel we have to continue to amplify in some way is some standardization of transitions of care. So the hospital, in various meetings that we go to, I've heard the phrase, a hospital is a commodity, which means it's there. But what's happening is the sicker and sicker patients are going to the hospital. The less sick patients are going to ambulatory surgical centers or other places. And so you find the resource drain in a hospital to be very intense. You have to have a system that is looking also at amplifying some of these other sites of care. And then how do we manage that patient going to the right site of care and then transitioning them from one site to another site, whether that be an outpatient to an acute care to LTAC, long-term acute care, or a skilled nursing facility. All of those transitions just have to somehow be better standardized. And we need to be able to get patients to a point where they feel like their care doesn't mutate so much where everything gets shifted again and everything has to be relearned. And everyone has to learn the whole thing again, right, as opposed to having, I'm going to tell the LTAC or I'm going to tell my outpatient doc exactly what happened in the hospital. These are the priorities of what need to be done outside the hospital. And while you wait to see your outpatient, we're actually going to, do some remote patient monitoring, or we're going to create some process where you feel comfortable leaving the hospital in an efficient way, but still be able to feel like you're being watched before you end up seeing your outpatient doctor. Those are all things that I think are going to be imperative down the road.
For sure. Taylor, for you, as you see AI and technology and things changing, what do you think? What are your feelings and thoughts as we keep moving forward? Because when I was in high school, we had the few people who had technology had pagers. That was it. So technology has changed so dramatically to where we sit today. What do you think? I mean, it's an interesting concept, AI, and how the knowledge is there, but how it's going to change things ultimately for us in our profession.
Yeah. Well, I mean, as a millennial, I've grown up with technology, right? I mean, I got, by the time I was in high school, it was pretty normal for a 16-year-old to have a cell phone, for example, when they drove. Now, it's not a smartphone. It was like the old school Nokia that's probably still in great shape in my drawer somewhere at home. But so technology doesn't scare me. It doesn't. I'm very pro that. I think that it can improve patient outcomes. It can improve care. I love the idea of like remote monitoring for patients, right? I mean, I remember when I did my cardiothoracic and vascular surgical training, having these patients who surgery went beautifully. Like they had a, routine care. They went to an LTAC, then they went home, and then they ghost their 6-week follow-up. Why? Because they passed away. They passed away at home, Right. And us thinking of things like, man, if there had been early signs and detection that something was going wrong with them, that they could have been evaluated sooner by the hands-on, team. Right. That's a way that technology would, continue to improve care for those patients where there is this kind of loss, this hill that they drop off of.
Sure.
So I think it again will unburden, I think, a lot of the administrative stuff that people who are still practicing mainly clinically have to do right now. Right. We were talking about the dictation of a short stay summary, for example. When we used to dictate that, it would take 2 minutes, maybe. Right. And then now it's down to 15 seconds via a couple of clicks.
Yeah, and that might even be extended in terms of the reality of how long it takes to click something.
Correct. And so I think as time goes on, yes, there's a learning curve, but the payoff is really good on the end of it as you learn it. As someone who's grown up learning, I started medicine when we were still doing paper charts, and Medicare had just changed all the stuff where, hey, if you want reimbursement, you have to have an electronic health record. So I watched all these systems go from paper charts to electronic health records and had to learn 8 different systems for my clinical year, right? I'd go to Memorial Hermann and have to learn Care 4. Oh, my next rotation's in League City, and they're doing paper charts. And then I would go over to Victoria, Texas, and they're using a Meditech, so to me, it's the mind is malleable. My mind works that way. So learning those systems is something that I look forward to. The thing I don't want to lose is the personalized care that you get from people. Yeah. Right. I would rather what that results in is less time of me having to do electronic charting and more time that I spend face to face with my patients going through, the intricacies of, when you tell people to just, you need to move more, you need to get out and exercise. Well, what does that look like for that person? What hinders you? What can we come up with that's a plan for you that's actually feasible instead of I'm running out of time. You just need to start walking more. Bye.
Right.
I think it's going to end up working out really well for our patients as well as hopefully reimbursement too. I'm thinking over time that'll get bigger and better too.
Yeah, I mean, certain technology definitely has led ourselves to that, right? So EHR, when it first came out, there's a computer screen between you and the patient. You're clicking. You still have just 15 minutes with the patient, but now you need 5 minutes to review the chart, 5 minutes to close the chart and do all the clicking. You're left with just 5 minutes for the patient, right? And that's just never really enough. Now, I think one of the biggest plus points in tech is the ambient scribe, right? So I think docs who are utilizing that, and again, proceduralists, the time for the visit may sometimes be shorter if it's, follow-up and those things, but primary care physicians and things like that, after they start to use that, I think it's difficult for them to go away from it because you have much more face-to-face conversation. You got this thing listening, and it comes back with a note that's 95% pretty good and minimal editing, and you don't have to worry about something being forgotten. You don't have to worry about, I got to click this and that. And as they start to merge that functionality from just scribing to orders, where you can start to say, okay, well, we had chest pain, I can order a stress test for you. Now the scribe is not just putting it there, it's actually then popping in with that order for you. That's the kind of cool stuff that I think are going to make the efficiencies better for the clinician
and I think
the actual patient relationship better.
100%. And I think the very interesting and crazy part about that is for people who have that mindset, who are going to allow technology to actually increase the authentic interaction between physicians and patients, between entrepreneurs and clients, between if you view it from that direction, I think that is going to be those people are going to ultimately be the winners because people crave that right now. Like I can call to order a pizza and I have to talk to a robot, right? If I get automated pharmacy updates, I get automated everything updates. And so I think the challenge is if you go into it with the idea that AI or something else is going to start to take that moment, from the moment between the two physician and the patient, then that's going to be the challenge. I actually was in a meeting, was on a podcast yesterday where they had an AI chatbot that was like they were employing to try to lead it, and without sounding like my teenagers, it was very cringy. Like it was super uncomfortable because it was like this thing is telling us what to do, but it has there's nothing there. And I was like, man, that is, to have it summarize it or to transcribe it or to even come up with interesting, cool questions that they could ask based on things would have been interesting to have two humans talk about it. But to have it prompt the entire conversation was very, very bizarre. And so I can imagine that happening, saying, hey, if you go to that next level where it's like, okay, well now in my clinic, the bot's you're going to do everything with them, and then I'll be in to give you a high five and sign you up for surgery. That ain't going to work. I just don't think it's going to happen to that level. But I think people who are employing that technology in a way that allows for that interpersonal interaction, right? If it makes life better for everybody, including the physicians, those people are going to just skyrocket. It's going to be really, really good. So that's exciting. So one thing we also have, we've got a book club. From the team loves it. We did Unreasonable Hospitality. Okay. Great book if you get a chance to read it. We're in the middle of Extreme Ownership right now. Do you have a favorite book or a book that you would recommend for us to add to the book club?
Well, if you haven't read the book Drive by last name is Pink, I think that's always good. It talks about kind of incentives and what actually drives our human emotions to do better. I think that's always a good one. There's a book called The Daily Stoic, which I also like. Stoic philosophy, I think, really aligns well for leadership and kind of management.
Nice.
So that those are a couple of things that might be good for you.
I would love those,
Pink.
and
Pink
I have not read either of those, so I will put them on the list for sure because I love finding good books that we can read. And so our team, we've got a 1 month cadence we're trying to go through and do. So you might have seen some candy out in the front and some waters and some. we've been working on making phone calls before and after clinic to try to increase that interpersonal interaction, which has made a huge difference. I mean, we've gotten a lot of great feedback. Patients seem to love it. So very, very cool.
Found it.
You found, yes, Taylor's got it. We're on. Very nice. And favorite pie is caramel apple pie from H-E-B, is what you said.
Yes.
So a little bit of a downer alert for you, because we're not actually sponsored by anyone, but just because I went by a pie place, I asked for caramel apple pie and they didn't have it.
Okay.
So you have apple crumble.
That's awesome.
You'll have to sprinkle some caramel on top of it so that you can be in good shape for that.
Absolutely.
But
That's
yes,
wonderful.
you've got the pie there. One of the last questions that we always ask is, what if Taylor and I could do anything for you? What could we do? How could we help you?
Oh, this is fantastic. I mean, keep doing what you're doing. I think it's just fantastic to see how you are leveraging your job with completely kind of a different mindset towards providing for your staff, providing for the community, providing for your patients, and just being an aspirational leader. That's fantastic.
Yeah. Well, thank you so much. We also have all of these super cool buttons. Mm-hmm. So
they're not as cool as he makes them out to be.
There we go. I love that.
If you ever feel like, man, I'm feeling a little down, you can just put the headphones on. If you push the wrong button though, that can make you feel a little worse. Or if you tell a bad joke. But so great friend, wonderful and amazing colleague. I mean, I can't thank you enough for being here and for the relationship that we've had, just getting to help lead together. You are not only a mentor, but a friend and also an inspiration. So thank you for that. I want to encourage you to keep leading from where you're leading, because I think that you're doing such an amazing job. And it's super refreshing for everybody, for all of us to be in a room with you. And I know that we didn't dive into like some of the crazy stuff, which we don't need to here, but there's also there's also difficult things that you have to do as a medical leader, as a chief medical officer, and dealing with physicians in difficult times, patients in their toughest times. And I think that you are an absolute just artist when it comes to doing that. And so I just want to thank you for that. Thanks so much for being here. Mm-hmm. And we'll play you off with some music.
Okay. Well, thank you so much for the great words, and right back at you. You're amazing.
Absolutely.
He's the only one who dances. So.
That's true.
He dances to the beat of his own drum.
Very true. Very, very true.
That's awesome.